Okay. Hope everybody had a good lunch and you got to go to the exhibit hall. We had some fun in the exhibit hall. It was a good time. So if you are going to be around tomorrow, we have more vendors in the exhibit hall. And if you didn't get a chance to go today to the exhibit hall, definitely make sure that you go in there tomorrow. We have a bunch of people coming back in, so I'm going to just wait. We have about a minute before Dennis is going to start. Dennis is live online from Milwaukee, Wisconsin. Yep. So it's exciting.
So
how's the weather in Milwaukee, Dennis?
It's gorgeous today.
Good.
I just want to know if somebody let me know what Elizabeth served you for lunch.
It was a buffet.
All right.
Yeah, you can pick whatever you want that you had in your refrigerator.
You got to fix it yourself.
I had a tuna fish sandwich. Okay, so one more minute. This event will run fully on time. No messing around. Okay, so Dennis, I'm thrilled to introduce Dennis Janisse, CPed extraordinaire, globally known speaker on pedorthics. This is going to be awesome. He is our 1:15 speaker, and then he is our speaker immediately following. So we're going to use the same room for this event, and as soon as this session is over, we're going to turn his camera on so that he can answer questions live. You still want to chat them to Dennis, and he can answer them live, and then we're going to do the survey. Take a couple of minutes just so that he can put his second PowerPoint back up, and then Dennis is going to do his second presentation, and we're going to end that one the same way with live Q&A and then the survey. And then if anybody is registered for the NCOPE approved clinical mentor program, that will be starting with Chris Robinson at 3:45. All you have to do is go back to the schedule page and click on the watch now for Chris at 3:45. And it says 3:45 to 4:45 on the schedule. That was before we knew that we had to, that it's actually 3:45 to 5:45. We can't change the time. The system won't let us, but just so you know. And I'm not going to speak for Chris because he probably will use all of his 2 hours, but if you register for that, you know that you've already been in contact with him. So sorry about the 4:45 on there. Didn't mean to bum anybody out, but you'll get all of your ACM. You should have finished all your modules already. So just a couple more people that were in the waiting room. I'm letting them in right now. And then Janisse, we'll try. I'm going to mute myself, turn off my video, and you are good to go. Thanks for doing this.
All right. Good afternoon, everybody. I've been doing some virtual meetings. Actually, obviously, I miss all of you. I wish I could see who was here. Hopefully, there's some people that I know. I'm sure a fair amount of you may know me. I am assistant professor, Department of Physical Medicine Rehab at the Medical College, consultant for Dr. Comfort, or DJO, and I still do have my own pedorthic practice, National Pedorthic Services, so I'm still in sort of in the trenches as many of you are, so I'm still practicing. So we're going to go through and talk about amputations, and I don't know the makeup of my audience. I am a certified pedorthist, so I'm going to stay pretty much within my scope of practice. We're not going to get into below knee amputations or anything like that. So we're going to stay within the scope of practice of the pedorthist, which is transmet and more distal. So amputation surgery, oldest of all surgical procedures. I think we can remember looking at history books where people are sawing people's legs off. Previously a life-saving but very destructive procedure. Obviously now it's a reconstructive procedure and very helpful to allow people to continue with their lives. Amputation requires judgment, planning, and meticulous handling of marginal tissue. Now, the reason I put that slide in there is because there are people, and I don't mean to be offending anybody, and again, I don't know who my audience is today, but there are people doing amputations on the foot that don't understand the biomechanics of the foot, and that can really be a big problem. I'll talk about that here and there, and we'll see some slides of it actually. But and again, I'm not being negative, but the foot is pretty complex. We know it's got 26 bones, all the articulations and everything else. And when we do an amputation, when an amputation is done on it, we need to be thinking, or hopefully the surgeon is thinking about what we're going to have give to us so that we can manage it. You know, some practitioners may look at it as looking at where is the infection, or where is there enough blood flow to heal something, and do the amputation with those guidelines. And for that particular person, those are the things that are they're conscious of in their expertise. But in reality, some of those feet that are amputated with that kind of criteria can give us a very, very challenging foot after it's all done. Amputation is not an admission of failure. And I think for a lot of us, you know, be it orthotist, prosthetist, or pedorthist, you know, I guess we probably don't want to see any more amputations, any more surgery than is necessary. But often the amputation, and again, if it's done properly, can help us, and we may be able to manage that foot much better after the amputation. And it's not an admission of failure. I know when I started in pedorthics, I wasn't going to let anybody have to have surgery. I thought I was going to heal everybody. Well, you know, get real. That's not reality, and in many times it makes our job easier, and it may be the first step in returning that patient to productive life. So possible causes of indications, we start with peripheral neuropathy, and you know, and we talk about peripheral neuropathy as loss of protective sensation. And that, when we're talking about diabetes, we're not necessarily just focusing on diabetes here, but with the loss of sensation, anybody that has peripheral neuropathy and loss of protective sensation, that can be and is a major cause of amputations. Vascular issues can be an issue, and a lot of other things, but that loss of protective sensation is probably the biggest cause of a lot of the partial foot amputations. Neuropathy can be not just diabetes. We expect a lot of it. We see a lot of it in diabetes. But always remember, I think that sometimes, even when I had a patient earlier today, we were talking about diabetic neuropathy. That's not part of diabetes necessarily. That could be the result of diabetes, but that's not a diabetic thing. It involves many different other etiologies. And, you know, Charcot-Marie-Tooth, rheumatoid arthritis, Hansen's disease, or leprosy. And, you know, we don't think about leprosy here, but there's leprosy all over the world. It still is very prevalent in some developing worlds. Spina bifida, certainly we see a lot of it there. Spinal cord injuries, alcohol. Sometimes here in Wisconsin with our brandy and our beer, I think alcohol might be the second leading cause for peripheral neuropathy. Exposure to heavy metals, certain chemicals, and just idiopathic neuropathy. I don't know about you folks, but I am seeing a lot of idiopathic neuropathy. Ask the patient, they tell me they've got peripheral neuropathy. Well, why? Well, the doctor doesn't know why. I recently had a fellow that had a midfoot fusion as a result of Charcot, and it totally looked like a diabetic foot. And it wasn't. It was they don't know why he has the peripheral neuropathy that he's dealing with, but he's got all the same type of complications that our diabetes patients have, and certainly we're used to those complications with the diabetic population. Vascular disease, definitely a cause for amputations, you know, partial foot amputations. And that can be a major problem, especially when you link it with that peripheral neuropathy. We've got somebody with peripheral neuropathy, loss of sensation, motor neuropathy affected the autonomic system, and then you throw a vascular issue into that, really magnifies the risks. Trauma and burns, And this is something that you should think about. I think when a lot of us are dealing with diabetes patients, we think of if with a diabetes patient, if they had an amputation, they probably got to a point where they had peripheral neuropathy and loss of sensation. But if you have an amputation that's involving trauma or a burn, thereby relatively normal foot, that foot can be hypersensitive rather than insensate. And I tell you, that's a real challenge. I mean, obviously, loss of sensation is a big risk because people can't tell you what's going on. But when you've got somebody that's hypersensitive, that just makes it very, very difficult to try and provide them with appropriate pedorthic modalities. I've had people with, I can think of one fellow with a traumatic amputation. The end of what was left of his foot was just tight, gleaming skin. I mean, it was such a thin layer of skin over the end, and I feel like every nerve ending in his foot was coming out the end of his foot. I mean, you couldn't even breathe on it. So always remember, just because they have an amputation, that doesn't mean that they're going to be insensate. They may be hypersensitive. Here in Wisconsin, again, I don't know where everybody is from. Elizabeth said you're from all over the country, but we end up with a lot of frostbite here in Wisconsin. And then, of course, gangrene that all of us are going to be seeing can cause amputations. So factors determining the level of amputation, and we're going to look at some pictures as well, but the extent of the infection. Obviously, if there is infection in some part of the foot, especially in the bone, that bone's going to probably have to go. That bone is going to have to probably be amputated. Vascular status, certainly, if the surgeon can't do something to increase the vascularity, the blood flow to that part of the body, you can't amputate something unless there's blood there to heal. So those types of things definitely do determine the level or what part of the foot is going to be amputated. And then, as I said earlier, functional considerations. Some of those amputations just aren't going to be real successful if the remaining parts aren't functional. And that's a major problem that I continually see in my practice. So we start with the transmetatarsal amputation, and here are some indications. Forefoot soft tissue loss. So here you can see a dry gangrene. It could be extreme infection, and even thermal. If we have somebody with peripheral neuropathy, loss of protective sensation or total loss of sensation, it's very easy for those folks to burn their feet. I've seen it here in Wisconsin with our deer hunting in fall. The guys will come in from deer hunting and put their foot up against a wood-burning stove and burn their feet. You've heard of soaking their feet in too hot of water. So all of those things can create problems that will contribute to that transmetatarsal amputation. Obviously, those toes aren't supplied by as much blood and as much protection as the rest of the foot, so they are more prone to becoming a problem in these situations rather than the rest of the foot. I hope you can see that picture that I've got there. You can see there now. Some people may think, well, just take 1 through 4. The little toe looks pretty good. The fifth toe looks pretty good. And just and that's a problem that the doctors are faced with. A lot of people, they have to agree to an amputation, and people obviously don't want to lose any more of their body than they have to. But look at the skin on this foot. It goes pretty significantly far behind those toes, somewhere mid-metatarsals, that the skin is dry and flaky. After you get past that, you can see the skin looks pretty supple. It looks much healthier than it does distally on that foot. So just taking those toes off probably wouldn't be a real successful amputation. It needs that transmetatarsal amputation coming back into the midfoot to really have a successful procedure. osteomyelitis or infection of the bone. And here you can see this, it looks like this fellow lost 4 and 5 anyway. And now you can look at the third metatarsal head is all infected and it's distorted. That's definitely going to have to come off. But when you get to a situation like that, when you're leaving just the first and the second metatarsals and toes, that can, in a lot of cases, be a very challenging foot to manage, because you've lost the entire lateral portion of the forefoot. And when you just have those, especially if you just have the first, but even the first and second just dangling out there, that foot needs a lot of protection pedorthically to be able to maintain it without transferring so much weight to it that they end up becoming ulcerated and infected and losing them as well. Mutilating or crushing forefoot injury. This isn't probably the best picture right after lunch for you, but here you can see this was actually a young lady. Again, like I said, I don't just have diabetes patients here. This was a young gal that worked in a warehouse, and a forklift ran over her foot. She went into the emergency room, and I guess it actually was at the medical college. Some of the residents thought they were going to do her a favor and put it back together. You can see the pins in there to sort of stabilize things. Needless to say, within a very short period of time, her toes were dead. You can see they're black and crusty, actually. So that wasn't a real good solution. And in some situations, that may be a below-knee amputation or something. But they actually did a transmed on her. You can see that one area, probably maybe the base of the first or second metatarsal, you can see there's a red spot there. She did end up with an ulceration there after the transmed amp, but we got that closed pretty quickly. And again, this is a young, healthy person. She was back to work in a very short period of time after her transmed and did real well. And in here we've got tumors, and the tumors can be a real problem. And again, I go back to, I'm repeating myself, but you go back to this, we can see the tumors definitely involve 2 and 3. 1 doesn't look like there's any problem there, and 4 and 5 don't. But those tumors, and I think we recognize that. I'm sure some of you have had and not that I'm an expert, I'm not a doctor, I'm only a pedorthist, but we've got situations where with breast cancer, I mean, some of my daughter-in-law just had to have bilateral and mastectomies, and a lot of the tumors have roots or feelers out there, and you have to be sure that you get all of the tumor. And I sort of compare it to crabgrass. If you go out in the garden and you pull up a piece of crabgrass, you could have all kinds of runners from that all the way down the whole garden, and they're all connected. And I've seen it because I've had the opportunity I've been doing this for 50 years, opportunity of working with some of the best physicians around. And I've seen cases where someone would just remove those tumors, and they don't recognize that there are these tentacles out into the rest of the foot. And by that kind of an amputation, after they do it, those runners or those roots that are in the remaining part of the foot can come back with a vengeance and just grow and multiply unbelievably. So with something like this, it looks sort of radical because that first toe looks good, and 4 and 5 look good, but that ended up in a transmetatarsal amputation just to be sure that they got rid of all of that tumor and remnants of it. Okay, so then we get into other types. Here you've got just the toes somewhere in the metatarsal phalangeal joints. Losing that great toe by itself doesn't seem to be a real big problem. If you lose the first metatarsal head, of course, that's an issue because that is pretty important when we're pushing off. Lesser toes can be a problem because if you lose a lesser toe, then the toes want to fill in and cross over. So, you know, that can be an issue. That example there down on the right lower screen, there you've got a fella that, and I've had like 3 people that look just like that, lost all the lesser toes, they left the great toe, and that great toe just curled over eventually over the total end of that foot. So it sort of reinforces the need for some sort of a filler. If it's just a toe that's missing, medially, laterally, you want to provide some sort of a filler there, because those toes, they'll shift or drift medially and or laterally. So you really have to be sure to provide some sort of a filler to, you know, you're not putting a lot of pressure on that toe to keep it in place. Basically, I like to just say you're sort of reminding it to stay where it belongs. On the left side, you can see a fella that's actually had some Charcot involvement at one point, lost his great toe and part of his first ray, part of that first metatarsal. I've had patients, I've had doctors that have said, well, that isn't all that big a deal. He's got most of his foot left. Well, what do you think happens with this? On any kind of a floor reaction imprint of this foot, the weight is very evenly distributed if he's just standing. But you do take a walking, a dynamic floor reaction imprint of his foot, and that second metatarsal head is all blue. It's all the color transfers there. And we have to remember that first metatarsal shaft is a great big, strong bone. And if that's gone, the pressure has to go somewhere else as the person starts to walk. So it will transfer over to the second. And just to talk, I don't know that we'll have time for case studies, but this was a fellow that I took care of for about 20 years until he retired. With shoes, rocker soles, foot orthoses with a filler there, and he was a mailman. I mean, he was delivering mail every day with that foot. So I think he's a real good example of the fact that, you know, we really can do a lot for these folks to preserve their feet and keep them on. Okay, we talked about the transmetatarsal amputation, and I think something to think about there is that transmetatarsal amputation it really can be long or short. You know, it's through those metatarsals, and you'll have some that are really, really short. I think the physicians recognize that they probably want to leave as much as they possibly can for that person, but it can be varying lengths with those transmet amps. Now, this would probably be what I'm told would be a good transmetatarsal amputation. You can see that the bones have been cut somewhat following the shape of the metatarsal heads. You've got sort of a crescent shape there. And that would be a pretty good idea shape for that transmetatarsal amputation. Now, they don't all end up that way. So we'll look at some pitfalls. And when I'm doing these, I want you to understand I'm not picking on any physicians or anything else. I just think sometimes it's helpful for us to see what's going on behind the scenes when these folks walk into our offices. So here's inadequate resection of diseased tissue. And here my suspicion that this was a doctor I work with, but I don't know the exact details here. But if you look at that foot, it looks like they tried to preserve a lot of length. But in the effort to preserve a lot of length, didn't get rid of all the diseased or infected tissue. So the person had this done and then actually ended up with more breakdown because of infection. So then what happens is they end up with a much shorter foot. Now the problem with that, the nicest transmets that we can get is one that they are able to take plantar skin and bring it up over part of the end of the foot. That's going to be the most durable for us because the most durable skin on our whole body is that plantar aspect of our foot. So if they can bring some of that up over the end, that's going to give us a nice buffer and that patient a foot that should be able to last quite a while by having that over the end of that foot. Here we see an uneven cascade of the metatarsals. And we saw that picture where I showed you how those metatarsal heads were were cut off in that transmet amp. Unfortunately, we don't always, maybe there's a reason they're not able to do that. So if you have metatarsal heads that aren't real functional, then eventually, and of course this could be what the picture we're looking at, maybe partly because of the type of insole the person was wearing, or maybe not wearing anything, but also those metatarsal heads aren't really in that configuration that we would expect them to be in, and then we get an ulceration. Probably most of you are familiar with it, but I think if I could ask you, you'd tell me that foot's probably insensate. Why? Because we've got all that callus around the outside of the ulcers. That person's walked on that for a long time to get that much callus around those two metatarsal shafts. I mean, what's left of their metatarsal shaft. So that's where we get into a lot of problems when we have the insensate foot, obviously, because people don't know. If this was a traumatic amputation and they had normal sensation, you wouldn't get to this point because it would hurt considerably. I think any of you that are watching this, if you had that kind of a hole in your foot, you wouldn't just be sitting in your office listening to me talk. You'd be somewhere to try and find out why it's hurting and have something done about it. So the uneven cascade of metatarsals is important. Here, when I said about not wanting to lose any more of your foot than necessary, and I see this, I don't see it as much. I used to see a lot of this. I won't say that I see as much of this anymore. But here's a situation where the person may not, just says only take what's infected, only take what you have to. And here you can see, it's basically a transmet length for 2 through 5, but that first metatarsal shaft is just dangling out there. It's gone out into varus, so it's not even in line anymore. And you see breakdown. And a foot like that could just have reoccurrent breakdown on what's left of the first metatarsal shaft, because all the weight is being transferred to that every time they take a step. Again, that would be a nice transmet, and it would be a very workable foot if it was done that way. Here's a situation where, and I see this very often, where the doctors end up leaving a couple toes. And again, I promise you I'm not being critical. I understand, because I've got a lot of physicians that are friends. The patients just won't give permission to take any more than they have to. And so here you can see they've got those 2 toes dangling there. And what happens with those toes, there's structure and function to them early on, but as time goes on, for whatever reason, they end up eventually losing function, and they're just a bother. They're dangling all over the place, and initially they may feel like they are glad that they kept them, but usually it isn't an advantageous thing. Now, when we look at the x-ray of this foot, when they did the amputation, they didn't remove the sesamoids, and I'm not sure why you'd want to leave those sesamoids there. But they left the sesamoids, and if you look up at the end of the medial aspect of the foot itself, you see a lot of callus there, and that could be the sesamoids, or maybe that sort of rough end of the metatarsal. And then 2 and 3 are much shorter than what's left of 1 and 4 and 5. So again, this would be a great transmetatarsal amputation, and just take everything off pretty much at that one level. Again, these are challenges that we have to deal with. I had a patient that I just came into our office recently that I had started with when he was a child. His dad had run over, I think he was like 4 or 5, 6 years old. Dad ran over his foot with a lawnmower, and he ended up with some skin grafting, but there too the dad says, don't do any more than you have to. So he left him with those 2 toes. Now, I've taken care of him here. We have an office in Madison. He was in Madison for quite a while, and I actually saw him with one of my practitioners here in Milwaukee. And I saw the name, and I thought, that can't be. And I walked in, and it was him, and he now has his own child. But I looked down at his foot. Kathy was casting him for a new partial foot. And I said, where are those toes? And he said, oh, Dad wanted me to keep those toes. And he said, he wouldn't let me do anything about it. So he said when I was in college and I could make my own decisions, he said I had them taken off. So they usually, that's not a real leaving, just leaving 4 and 5 or 5 on, usually isn't a real good decision. They become a bother almost later on. Okay, and then the unrecognized sort of post-op, I mean peri-op, but it's also post-op, gets worse, equinus contraction. A lot of these folks that are having transmetatarsal amputations, they're having the amputations because of ulcerations on the dorsal part of their foot. And that very often is because that foot was going into equinus. A lot of these are again, we can go back to our diabetes population, or just situations where people have been very sedentary, and when people are very sedentary, that foot tends to go into some equinus. Then when people are walking, all the weight, all the responsibility is on the forefoot, and that really can be the cause for a lot of those forefoot amputations. Then after the amputation, most of the dorsiflexors are gone. If you do a transmet, as you see here, most of the dorsiflexors are gone, but you've got real strong plantar flexors pulling that foot down. And so it's a very big problem. You get so much pressure because that forefoot is plantar flexed, and people are just banging and banging and banging on it. I think most of the physicians, I'm sure most of your physicians, if they saw a foot like this or did this type of amputation and there was an equinus contracture, would do a Achilles or gastroc tendon lengthening, and that really helps these feet so much. This is a really tough foot to deal with. If they do that lengthening, it makes that ankle joint very, very supple, and you can manage this foot very easily and avoid further ulcerations distally on what's left of the foot. That's one thing. I don't talk many people into surgery, but that's one that I actually do talk people into, and just try to help them understand how important it is to have that surgery. And it's really not that big a deal. The patients have told me, I've never had it, but the patient said it's not really that big a deal after they agree to have it done. So, yeah, obviously you can't tell your physicians what to do, but hopefully most of them at this point understand that that's a pretty necessary thing to the success of that foot. All right, well then, the only other amputation that we really would have anything to do, because we get back to the show part and the signs, those types of things are out of our scope of practice, would be a calcanectomy, and the heel is still on the foot, so that's still in the pedorthus scope of practice. And you can see here, this was a total calcanectomy. I have a lot of patients that come in just with partials, with severe fractures of the calcaneus, and that can be a real challenge because as we walk, you know, everybody's coming down on that calcaneus. It's absorbing all the shock on heel strike. So this can be a real big challenge. Here we can see one that actually this doesn't look too bad. This heel still has a pretty nice shape to it. This is a device that we call the hindfoot containment orthosis. Anybody could make something like this. We made a very, very high heel cup. We usually try to come above any scar tissue or out of the shoe. Once the scar tissue is out of the shoe, it isn't too much to worry about. This is number 2 plastisode. It's yellow. You're used to seeing that as white, but this is number 2 plastisode. And you can really mold that and get a real nice heel cup out of that. Mold it, and then what we actually do is fill in the void. If there's a void in the heel, fill that in with a real soft viscoelastic polymer, and then we wrap fiberglass tape around it and get it a very, very intimate fit. You want a real intimate fit on that heel. And I'll show you here why. Here's another situation, and this fella lost all the fat pad, everything under his calcaneus. So they did a muscle flap with a skin graft over it to protect it and provide some shock absorption. But that muscle that they put under there for cushioning isn't attached to anything. So you can see on the middle slide, you can see where that little circle of muscle was put. You can take that piece of muscle and move it from side to side. So it's good, it will provide some cushioning, but it's got to stay under the foot. So what happens if you don't have something adequately to keep it under the foot, it will move to one side or the other. So that's the advantage of using this hindfoot containment orthosis. You can see how we made it there. When you put that on, it's actually, you have to manipulate it onto the foot. You want a very, very intimate fit with that. That will keep the heel pad, the muscle that they put on there, under the foot. And then you've also provided some soft material, be it polyurethane foam, the viscoelastic polymer, whatever it is, as cushioning. And that device works very, very well. It's very bulky in the beginning because, of course, with that muscle flap, it's very, very bulky. Over time, the muscle flap actually atrophies and it gets smaller. So in the beginning, this device is very bulky. After that atrophies totally, and sometimes with these patients, we have to make 2 or 3 of them till they get to the actual foot that they're going to have at the end. And then many times they can go into a regular size shoe. We'd have to oversize the shoe in the beginning, but at the end you might be able to, you can probably put it into a depth type shoe. Okay, so that's just a little bit of an overview of the different causes and reasons for the transmets or different types of foot amputations. Now we're going to look at pedorthic management. So obviously we want to improve gait. The foot, the entire foot is responsible for gait, and each part of that foot has an integral part. I mean, you lose one toe, it affects it. So with our pedorthic objectives, we're going to try and do whatever we can to improve that gait and get it back to normal, as normal as possible. Provide a filler for the amputated foot. Now, I'm not obsessed with the filler being made out of any particular material. The filler, in my mind, is to fill the shoe up, not to hold the foot in place. A lot of your patients will look at that and they'll think that they should butt up against the end of it to hold their foot back in the heel so the heel doesn't slip. And some of those people, that's probably the way they bought shoes as well. That filler should be fit like you fit a shoe. There should be some room between the end of the foot and the beginning of that filler. If not, regardless of what you do to that shoe is going to bend some. And if the filler is right up against the end of the foot, you could get some shearing, some blistering, and some breakdown on the end of that foot when they're wearing it. So the filler is there to not let the shoe, not to hold the foot in place, but to maintain and fill up the rest of the shoe. If you don't do that, you will get a lot of wrinkling, and I've seen situations where that happens, and then people get breakdown dorsally because of the creases that appear in the shoe, because the front of the shoe, the toes aren't there to keep the shoe flat. So the filler is important, but it's not to maintain position of the foot in the shoe. Equalize weight-bearing pressures. Again, if we've lost some of the metatarsal heads or part of the foot, then the foot's not going to function properly, and weight has to go somewhere else. When we do things to offload, always remember, wherever you're doing, if you're offloading something, you're not dissipating that weight-bearing responsibility into outer space. If you're offloading, that weight, that responsibility is going somewhere else. So we always have to remember that. Protect and accommodate the remaining foot goes without saying. Contain the foot in the shoe, and that can be a challenge, especially with the real short transmets. And of course, decrease shear and friction. And that's something that I've talked about for years. I've been doing this, like I said, for 50 years and lecturing most of that time. And I used to say decrease shear, and then I never said anything about it again. We've got things that we can do. There's socks and different materials that we can use to decrease shear. You will tend to have a lot of shear with the foot that's had an amputation because it doesn't fill up that shoe, and it's harder to control it. So you are more prone to having some shear issues. So shoe modifications, Obviously, the rocker sole is something that we want to take a look at. If we've had a transmetatarsal amp, maybe not so much with the toes, but a transmetatarsal amp, they don't really have anything to push off with, so we would want to go with a rocker sole to assist with push off. And that also will decrease some of the distortion of the upper of the shoe as well, because the shoe isn't going to be bending. A heel to toe rocker sole, in my mind, would be the best, because you have a nice smooth progression from the heel to the toe. Some sort of a shank, and I tend to use primarily steel shanks personally. There's a lot of carbon fiber shanks that we can use as well. I just find the steel easier to bend, because the secret behind using that steel shank is having it made the same shape of that shoe. I mean, it's got to follow the contour of the plantar aspect of that shoe. If you put that shank in there and you don't bend it to the shape of the shoe, it's going to work its way out of the bottom of the shoe, or sometimes it comes through the inside of the shoe. So the steel or carbon fiber, but the rocker sole is going to be so much more effective with a shank in it, and also it gives some spring, some propulsion for that person that doesn't have their forefoot during gait. Medial and or lateral flares. You know, again, a lot of those folks with the transmets especially, even though they've had they might have had the lengthening, there still tends to be somewhat of an equinus lateral move of that heel and of what's left of the foot. It ends up being sort of supinated, and they do end up going off toward the lateral side. So if that's happening, putting a lateral flare on that shoe is such a good solution. It's an easy thing to do, and it really helps stabilize the foot. Also look at the shoe that they're wearing. They may have a shoe that has a very narrow base on it, and with those folks it would be better to have something with a medial and lateral flare built into the shoe. And we've got a lot of stability shoes out there right now that have that built into the shoe. A satch heel or a cushion heel, as that foot gets smaller and smaller, remember that the foot the feet are the shock absorbers for the whole body. And if you lose parts of that foot, you're losing some of that shock absorbing property of the foot. So the satch is a great material. It stands for solid ankle cushion heel, and it's used in prosthetic feet. I don't think we use a lot of those in the United States anymore, but when I'm out of the U.S., especially in lower resource countries, a lot of satch feet are being used. You can buy satch in a block and cut it off, and I use a lot of satch for these patients to decrease shock on heel strike. It's also a great thing for those calcaneal fractures. It's awesome. In fact, there's orthopedic papers written on calcaneal fractures that they recommend using a satch heel. So think about that. It just really helps with that severe shock on heel strike. The total contact foot orthosis, now here it can be a little debatable on using a carbon fiber foot plate or an extended steel shank. I feel like I've got a pretty good rapport with most of my physicians that refer a lot to me, and if someone has diabetes or has peripheral neuropathy and significant loss of sensation, I prefer going with a steel shank installed in the shoe and a rocker sole. If it's a transmet that's a traumatic transmetatarsal amputation, or even the toes, I'm not at all opposed to making a filler or a foot orthosis, whatever, for them and attaching a carbon fiber plate, because they have sensation. They know what the shoe feels like. In my experience, doing the carbon fiber plate on a partial foot for someone that has no sensation, I've seen some real disasters. If they buy a shoe that has a significant toe rock, it won't be an issue, but people aren't always doing that. And if they have a shoe that doesn't have enough toe rock, it really can cause a lot of pressure and issues with the forefoot. You put it in, install it into the shoe and put a rocker on, and pretty much you don't have to worry about it. When we make any kind of a foot orthosis for this group, I'm still an advocate of number one pink plastisode. And I always tell the story that I was at a large O&P meeting. It probably was AAOP or the Academy, and I was doing a presentation like this, and somebody in the crowd, and it was a couple hundred people at least, raised their hand and they said, "I don't know why you use that crap. It bottoms out right away." And I said, "I use that crap because it bottoms out right away." And my reasoning there is, and I just explained that to a patient today, we put that plastisode on there and it's going to bottom out, but it's going to take on the last shape of their foot, especially for my diabetes patients. It's going to take on the last shape of their foot. Any way you took a cast, plaster, foam, scan, they were all static. They were not dynamic. And once you put that into the shoe and the people start walking, that's a dynamic foot, and that's very different than the static foot. And that plastisode gives a little bit of adjustment. That plastisode will adjust to that dynamic foot that our insensate feet won't recognize. They don't know if there's still some pressure on there. So using the plastisode there just is a little help for me, a little assurance that that's going to fit properly. So I like the number one plastisode on top. You only need 1/8 of an inch. You don't want to go crazy on it. And always remember, it's going to bottom out really quickly. It also can act as a dynamic flow reaction imprint. You come back when that patient comes back, you take the foot orthosis out of the shoe and look at it. And if you tried to offload a certain area, you can see that offloaded area. If that plastisode is totally bottomed out there, you didn't offload it. And you can see around the outside, it probably is still 1/8 of an inch, so you can feel comfortable that you can offload more and load up that other area some to effectively offload the area you were trying to. Okay, I talked about what I use for the filler. I'm not obsessed with any particular combination of materials to fill up the rest of the shoe. I just want something there that's gonna hold up the shape and hold the shoe and provide a filler. Intrinsic posting. I will do some intrinsic posting for the insensate foot, but I'm a little bit leery on it, especially if you've got a foot like a Charcot joint, a foot that had Charcot involvement, something like that, because those feet are changing, and the intrinsic posting isn't as easy to modify as extrinsic posting. So it sort of depends on the situation, the patient, and what you're trying to accomplish. Doing intrinsically, if we're giving relief spots and things like that, it works very, very good. Metatarsal pads and wedges, those are things that are a little more complicated to change with intrinsic posting. Not that it can't be done. Extrinsic, this isn't a real pretty orthosis, but with a lot of these feet, if they're continually changing, we want to have the ability to be able to change it. This particular one, I put some PQ under the metatarsal heads. There was a metatarsal bar. Still had too much pressure on 1 and 5, so I actually loaded 2, 3, and 4, probably a Pescavus foot. With the extrinsic, it doesn't look as pretty, but we can do a lot more offloading and adjusting with that. Okay, here, of course, a filler for a partial foot. So then we can get into some AFOs. I'm not going to, again, we can do, as a pedorthist, I can do a scaffold or a gauntlet type brace. We use a lot of those for post-tib hindfoot problems. But you can actually take that same brace and put the toe filler portion onto it. So, and that can work very well. It will help offload the foot, and it's, in a roundabout way, it's force compliance. But the people will be happier with something like this because, in some respects, if it's a real short amputation, because then the shoe is going to stay on their foot. They don't even have to worry about it. And it's excellent protection for post-wounds, post-ulcerations. This is a device that actually my boys and I came up with. It's called a mezzo. And again, it was designed just the hindfoot portion for subtalar issues again. But then you can go ahead and put a toe filler part of it on there. And if you don't need to lock up the ankle, a design something like this can be very effective. what's nice about this, the insert comes out of it. So if you need to do some modifications to accommodate the foot, that insert comes out, and it can also be replaced. You've got a life expectancy with a brace like this, but you can replace the actual insole inside of it. So, you know, these are different options that you could possibly incorporate for those transmetatarsal amps. So follow-up is really important, and you know, this was a lady that had a transmat amp. This was, it was actually a patient of mine, and I was in the clinic with that physician, and the lady came in with a new ulceration, and he looked at me, and it was somebody that was he's very, very conscious of pedorthics. I mean, he's number one in my book. He was anyway. Unfortunately, he's passed away, but he came in, he looked at me, and he said, "When did you see her last?" And I called my office, and it'd been like a year and a half. And that ulceration, maybe she would have gotten it, but good chance that came from the material breaking down. Her device was broken down and probably contributed to that also. You can see there's a prominence there, but that foot orthosis breaking down in that area didn't help any. So we sort of, this is a long, long time ago, we sort of went to a different concept and follow-up procedure with our patients that have had amputations. With diabetic or neuropathic patients, we advise or encourage a follow-up every 6 months. We don't charge for that visit. You'd obviously have to make that decision yourself. And we actually send out reminder cards at 6 month intervals, just to try and get people to come back and let us take a look at what's going on. Because the lady I just showed you, she probably could have avoided that ulceration if she'd have gotten back, and we could have seen what was going on. We could have just recovered the device. It wasn't that it was worn out. It was just that the plastizote and the polyurethane underneath had bunched up underneath there. And it's really important because especially when we're looking at diabetic patients, their foot may be changing. So what you did for them 6 months ago, their foot may have changed, and the foot orthotic or the shoe modification may not even be appropriate anymore. So 6 month intervals with these folks is a good idea. And at the same time, they may decide they want another pair of shoes. The shoes may need to be repaired. So it's really an important thing. Now, I would be lying if I told you that we get really good follow-up with that. We really don't. I'd like to see more people come in, but that's what we suggest. With traumatic, I don't send out cards or anything, but I do advise that they come in annually for us to check out their footwear and their shoes. The fellow that I told you about that his dad ran over his foot with a lawnmower, when he came in for replacement of his device, there was a hole literally all the way through the foot orthotic under his first, the toe filler under the base of his first metatarsal. It was just, there was a hole, you could stick your finger through it. But he was traumatic. He had good sensation. He had callousing there, and he knew darn well he should have come in to see us. But he didn't have an ulceration. He had bad callousing and needed to have it renewed. So traumatic, if they've got good sensation, I personally am not as insistent on that follow-up when I'm talking to the patients. So that is that. I don't know if Elizabeth is there. If there are any questions, I can try and answer them for you folks.
Thanks, Dennis. That was awesome. You're right about the lunch thing, though.
Oh, did you get the leftovers?
I looked away a couple times, but that's all right. Okay, the chat is open. If you have questions for Dennis, please send them in the chat, and then he can read them, or I will read them, and he can answer them live. And I'm going to turn your camera back on, Dennis, also. So.
Well, then I should get out of this picture.
Yeah.
Great. Elizabeth,
yes.
Can y'all hear me?
I can. Bill, did you just unmute yourself?
I don't have chat
Rascal.
on my phone, so I'm just going to. Can I pose this question?
Yes, go right ahead. I'll be quiet. Yep.
All right. So Dennis,
Yep.
I'm trying to see if you're familiar with any product that fits this bill. A quasi crow, a product that fits the foot and ankle intimately, but has the upper portion more like a boot, like a fracture boot that you can bend.
Yeah.
But the portion that fits the foot and ankle of a Charcot ankle foot, you know, deformed, unable to be fit into off-the-shelf boot, anything that you know of.
Yes, but there's a system called OWL, I think, OWL. Have you seen that? I think that's what it is.
That's pretty custom.
That's custom? Oops. I think I lost you. I'm sorry. So you're looking for something that that's not custom. I can't hear anything, Elizabeth.
I don't think Bill is muted. His microphone is still on, so I think he may just be me calling in. Hey, Bill, you want to just chat it? Because Dennis and I are having trouble hearing you.
I can't hear anything now, except Elizabeth. I'm sorry.
Yeah, Elizabeth,
There you go.
good. She cut me off.
Perfect.
That's good.
I didn't cut you.
Oh, yeah, but it was her fault. Everything is.
Okay.
Right.
Go ahead, Bill.
So you were looking for something off the shelf, is that what you said?
That's right. Off the shelf.
Yeah.
You crack the last total contact cast off. The crow's not there, and they want to put them on something that's removable, but you want to be able to make sure it fits, and you can bend it and shape it and.
Oh, no, I do not know anything like that. I'm not aware of anything like that. That would be awesome.
You know, there's a couple of companies that sell what they call diabetic boots, you know, for Oster has one, the DH offloader. Bragg has the Bledsoe diabetic boot. I'm just curious if you've seen people using those and know.
Well, I think I know some of our docs use those types of things. I mean, in particular, some of them are very wide in the midfoot. So there's room if you've got that a midfoot Charcot, you know, they're wide enough to accommodate it. That's the problem with a lot of those boots. They're so narrow in the midfoot that it wouldn't work. But there's some of them that are wider in the midfoot, and then what they'll have us do is make a custom foot orthosis to go inside of it.
Right. Okay. Well, that was my question.
Thanks. But I think somebody should come up with one that's really, truly moldable, and it would be a good product.
Okay. So do you have any more questions for Dennis, chat, or rogue like Bill? If not, I sent the link out in chat for the survey for Dennis's presentation, and we are going to get him started on his next presentation. So everybody's just is a little bit patient. Dennis, can you switch out your PowerPoint for your next PowerPoint? Okay.
I'm in the process.
Okay.